In the following, I would like to look at the individual surgical procedures. I would like to start with the classic Wertheim-Meigs procedure. The extended radical procedure for cervical cancer is based on the operation originally described by Ernst Wertheim. This radical surgical procedure consists of extended hysterectomy with resection of the parametrial tissues, including the uterine blood vessels. In addition, a cuff of the vagina is also resected with the aim of achieving adequate surgical margins. In the case of an adenocarcinoma, the procedure also includes bilateral removal of the tubes and the ovaries, like you can see on this case on the right side. Historically, then Meigs added lymph node dissection to this radical surgical procedure. Systematic pelvic node dissection is the current standard of care. In the region of the lymph nodes of the common iliac artery, an intraoperative frozen section is performed. Para-aortic lymph node dissection in this case is only performed if there is a confirmed involvement of the common iliac lymph nodes. On the right-hand side of the slide, you can see a Wertheim specimen showing the structures mentioned before. This approach can also be performed laparoscopically. The published data demonstrates equal oncologic safety and shorter hospital stay and less perioperative morbidity for the patient. Now let us look at the modifications of the Wertheim procedure. These modifications are based on the idea of a radical surgical procedure with adequate safety margins. They are divided into types 1 to 5 according to the PIVA classification. The modifications are shown on the following slide. The driving factor here was the attempt to avoid or minimize the side effects which can result from the surgical procedure, particularly bladder and rectum dysfunction as a result of injury to the inferior hypogastric plexus and sexual dysfunction. The surgical complications of the radical procedures were one of the motors leading to the development of the modern surgical approach known as the compartment model. This model is based on the concept that cancers spread for a long time within their embryological compartment. This means that the spread of the cancer does not follow surgical boundaries, and that the goal of the surgery is therefore not the achievement of adequate surgical safety margins, but the resection of the entire embryological compartment concerned. We see that the surgical removal of the embryological compartment will improve local tumor control. A further crucial advantage in the comparison with the classical Wertheim-Meigs procedure is that nerve-sparing surgery is possible and that the inferior hypogastric plexus is spared, which means a significant reduction of patient morbidity. Finally, the procedure seems to eliminate the need for adjuvant chemoradiation. This has been proven in a large single-center trial on 125 patients. The relevant compartment in this case is the Müllerian compartment, which includes the uterus, the tubes, the vagina, the mesometrium, comprising the vascular mesometrium and the dorsal mesometrium. The TMMR model requires the removal of the entire Müllerian compartment. I will discuss the significance of this procedure for the prognosis in more detail when I come to adjuvant chemoradiation. On the right-hand side, you can see a resected specimen. It demonstrates a difference to the Wertheim procedure, and I especially would like to draw your attention to the vascular and the dorsal mesometrium. Because of the lack of time, I cannot go more into detail into TMMR procedure, and therefore I would like to refer you, if you are interested in more detail, to the publications of Höckel et al. Published in the Lancet in 2005. On the next slide, I would like to present results of this surgical TMMR procedure to you. This single-center trial by Höckel et al. Included 125 patients from stage 1B to stage 2A cervical cancer with a median follow-up of 50 months. With regard to these impressive results, it is very important to mention that these patients did not receive any form of adjuvant treatment, especially no adjuvant chemoradiation. This brings us to the next surgical procedure, exenteration, which is the most radical surgical intervention for cervical cancer. Exenteration or total exenteration involves resection of the rectum, the entire internal genitals, the bladder and the urethra. This surgical procedure can be extended to lateral extended endopelvic resection, which is the absolutely most radical surgical procedure for cervical cancer. Subforms of exenteration are anterior exenteration and posterior exenteration with resection of the internal genitals and the rectum. Depending on the type of exenteration performed, reconstructive surgeries such as creation of a neobladder or sigmoidolectomy should be considered. In most cases, the excessive trauma caused by exenteration should be weighed against primary chemoradiation, which provides equal tumor control in cases that involve pelvic sidewall, bladder or the rectum.